else, but it's, yep, 6 to mute and unmute and *9 to raise your hand.
Perfect, perfect. Okay, so we're gonna go ahead and get started. Welcome to the North Dakota Brain Injury Network's webinar Wednesdays. We are, hosting these in partnership with the American Heart Association, their stroke project. So we are excited to be offering them and are doing them every other Wednesday. But at this point, I don't believe we have one just scheduled up. We're firming up the next few. Because of current situation, we are having a little bit of issues, but welcome. And they will be archived on the website. And once they're on the website, there will be a place to select for CEUs and those pieces. And I should introduce myself. For those of you that don't know, I am Rebecca Quinn, the director of the North Dakota Brain Injury Network. And today we're going to talk about screening for brain injury. Definitely something that is kind of near and dear to my heart. I think screening for brain injury is something that we are not doing enough of in the human services behavioral health field, and we really need to do more of it. It is something that I definitely recognized when I started in brain injury. Up until that point, I really didn't think that I'd worked with any clients with brain injury. And when I interviewed for the job, they even asked me, like, what background do you have with brain injury? And I could think of maybe 2 clients when I had done hospice social work that had had a brain injury. And then I delved into the world of brain injury. Again, shockingly, they hired me given I had that background. But that was many years ago. And I delved into brain injury and really learned about it. And as I did, it kept coming back to me going, oh my gosh, I had so many individuals that I worked with that had brain injury that I had never recognized it. And I never realized how much the brain injury was impacting them and impacting their ability to access my services. And if I had known and been able to modify services better, I would have it would have worked better with that individual. So I think that's why screening is definitely something that I continue to push as something that should be being done universally across the board through different agencies and organizations. And it's something that as the Brain Injury Network, we're here to help with. So I'm going to go through the presentation today. And as part of that, we will have, I'm going to do an overview of the kind of some various screenings that are out there. And then they're mainly cover 2 screenings. I don't have one that's a favorite, so that's why I'm covering both. They serve different purposes. And it's really something that if you as a professional or as an agency want to adopt a screening, that's something that we would be able to work with you on and really select which one would be the best one for you. One of the things that I think is really important to understand is as part of screening for brain injury, a lot of times when we think about brain injury, we think that everybody that has a brain injury self-identifies and is going through the world kind of saying, I have a brain injury, and is really recognized and known, they will come forward and say, I have a brain injury, that there isn't this population out there that is unknown. But really what numerous studies have found is there is this population out there that's unknown. And so this just covers the numbers of brain injuries that occur. And of course, these are from the CDC and they cover TBIs. So these are traumatic brain injuries numbers. But as you can see at the bottom of the pyramid is those that receive other or no care. And a lot of times those might be people for whatever reason don't access medical care. And so they're not even counted in the numbers when we think about how many, in the United States, 2.5 million brain injuries are happening every year. We don't even count those people that don't seek care. So there are people that don't seek care. There are people that maybe seek care that are told, they just had a concussion, it'll be okay. There are people that haven't been told that it's a brain injury, or they had a brain injury, but they haven't been informed that they're long-term impairments. These do go through the severity level of brain injury. And one of the things that I included this slide is just because when we think about long-term impairments, you know, even for a mild brain injury, which is what we traditionally call a concussion, 15% of those will have been identified as having long-term impairments. So even for a mild brain injury, it is something that can be impacting an individual. Within moderate, 30 to 50% will have long-term impairments. A moderate brain injury is a longer than 30-minute loss of consciousness, but a less than 24 hours. So that might be somebody that's unconscious for maybe 45 minutes to an hour, maybe does, you know, some time in an emergency room and is discharged home, but really didn't have that understanding of, yes, I had a brain injury. So you can see where it is possible for individuals to have these long-term impairments, but then not be aware. And so another piece that's important about that is this idea that mild can be a misnomer. We have definitely learned over the years, particularly through research through like sports concussions and veterans, but even more so now in other populations, that the degree of physical injury does not always equate to the degree of long-term functioning. Particularly this idea of multiple mild. For individuals that have had maybe 4, 5, 6 mild injuries, those start to become cumulative, and they maybe would never identify as having a brain injury, but they they have, you know, have these long-term effects. So they might say, oh yeah, I've had, you know, 6 concussions, or yeah, I've been knocked out 6 times, but nobody's ever equated that it might be a brain injury to them. So, and definitely one of the things that brain injury is known as is the silent epidemic. The silent epidemic, the invisible disability. Injuries are often forgotten about, particularly once they're physically healed. The person may look the same. There really are very few conclusive measures, really not many ways of determining, yes, this person has had a brain injury. Individuals are often told they would be fine. So a lot of times the information that they're given may be that they, you know, would be fine, things will be great. Unreported and accidental injuries, minor blows to the head, all of these make it kind of this silent epidemic. So one of the biggest things is, could it be a brain injury? Could there be some underlying brain injuries? Because definitely, as I said earlier, screening programs have shown that brain injuries definitely hide in plain sight, particularly in high-risk populations. I really quickly am going to go through a few of the high-risk populations that the screening instruments that I'm going to review with you today have been used to come up with this data. So the first is criminal justice. Studies show that there is a high prevalence of a history of TBI within prisoners and those that are incarcerated, as high as 60 to 87%. Minnesota did a study and their numbers were quite high. So in the Minnesota study, for those that made it to incarceration, you know, 82% of their males, 90% of their females, and 99% of their juveniles had a history of head injury. So quite a significant number amongst criminal justice population. And I will say that these studies have been, within the criminal justice, is probably the population that's been studied the most. There have been numerous studies showing these high numbers. Colorado has been the most recent one to be doing studies amongst their criminal justice population. Nebraska. So Nebraska just recently got done doing a domestic violence study. And in that study, they found that 58% of the women who were screened tested positive for brain injury. They, they then looked at symptoms and what were the symptoms that these women were having. And really found that the most common symptoms were anxiety, depression, headaches, insomnia, changes in relationship, difficulty concentrating. So definitely we're able to show that, majority of the women that they screened tested positive for brain injury, and then showing that they were having symptomology that were impacting them. The homeless population. So in 2014, Toronto did a study. They found that 45% of homeless men were found to have a history of brain injury. For 87% of them, it was prior to losing their home. And a majority of them, it was as a child or teen. And the top causes were assaults, sports and recreational, and motor vehicle crashes. The next population is substance abuse. Studies estimate that about half of individuals accessing substance abuse services have a history of brain injury, and about half of individuals requiring inpatient rehab have a history of substance use disorder. And then studies also estimate that about 10 to 20% of individuals with brain injury will develop a substance use problem for the first time after their injury. One of the things I will say is significant also with the substance use disorder population is we know that use of substances can increase risk of acquired brain injuries, particularly from like overdose. So if an individual has an overdose, that can be an oxygen deprivation period where they may have an anoxia injury from not having that oxygen to the brain during that overdose. So within the substance use population, there's the additional history of, traumatic brain injuries, but also really wanting to look for that history of, acquired brain injuries as well. Another thing that I think is really important and why really wanting to look for look for a history of brain injury amongst any population you're working with and really be an awareness of that is the heightened suicide risk. Studies have shown that individuals with a history of brain injury are at heightened risk for suicide attempts and suicide completion. So there was a Danish study recently done that did find that even 7 years after an injury, traumatic brain injury patients still faced a 75% higher risk of suicide. They did find that all types of head injuries and all levels of severity were tied to the increased risk, but severe traumatic brain injury did have the highest risk. They have are doing some follow-up research on that, looking at is part of it related to the symptomology of the brain injuries, such as like processing information and impulsivity and inability to, reach out for help, those type of things that really can make that increased risk, and also some of the loss of roles and that grieving from a previous self and changes after the injury, and those being part of that heightened risk. So that kind of covers all of the why as professionals would screen. Screening definitely, when thinking about why, an agency should adopt screening or a professional should adopt it, thinking about, that screening, one, can be leading to more effective treatment. Whatever your role is working with individuals, you're going to be more effective at it if you're able to identify those individuals that have a history of brain injury, and as a result may potentially have some of the common symptomologies of brain injury, and be able to adjust your treatment for that. Another piece is new treatment options. Being able to, maybe refer them to a different provider type. It might be if they're having difficulty with organization, difficulty with attention, maybe benefit from some cognitive therapy provided by a speech therapist. So the ability to reach out and provide some new treatment options. For individuals, it also definitely is a chance to provide those individuals with that self-awareness. that piece for them to really have gain a better understanding about themselves and how they function, being able to identify pieces about themselves. Particularly a lot of the individuals that I work with, you know, I've been doing screening at Southeast Human Service Center and some other agencies around. And one of the things that definitely with identifying it, for a lot of individuals, they feel that it's kind of an aha moment for them of being able to say, oh, this is why I have problems in this area. This is why. And for them to be able to gain a better understanding, and then to be able to do the self-advocacy piece. You know, I worked with a client just last week who was able to have the self-advocacy from learning about his brain injury to say to a provider, I do better when everything is written down. So at the end of our, you know, session, can you please, you know, jot down, you know, 3 to 4 takeaways for me so I can carry them home with me. So he was able to, you know, like self-advocate for what he needed because he had learned more about how his brain functioned after his injury. The other piece is screening is relatively easy to implement. It's not difficult. Both of the tools that I'm going to go through today are not proprietary, so I chose ones that were free and would be easy for any, you know, provider or agency to implement. So that definitely is, it's not a difficult process. So one of the questions is why use a screening tool? The development of a screening tool, as I said, it's easy to implement, but you do want to select a, you know, identified tool and a tool that's been developed. For a lot of places that I've seen is they might just ask a question regarding if somebody has a brain injury or have they had a blow to the head, and it may even be part of like a long intake list of like all of these medical conditions. And what they really have found, particularly if asking, you know, if somebody has a brain injury, if an individual doesn't self-identify as having a brain injury, they're going to select no on that. But if you then ask them, you know, follow-up questions of, have you ever been in a car accident and, you know, been knocked out? They might say, oh, well, yeah, I had that, but that's not a brain injury. So really studies have shown that there needs to be a screening tool that has ask, you know, more detailed questions to solicit that response to really get to whether or not the individual has had an experience that would lead to a brain injury. So it's kind of the benefit of a screening tool versus just incorporating a question related to, have you had a brain injury? So the tools that we're going to go through today were designed to ask those specific questions and really have been set up to help recall kind of forgotten information. So as I said, there are 2 available tools that we're going to review today. They're both widely used. So there's not really one that's more used than the other. They both are free to use. They both have some pros and cons, as I said. So the first is the HELP. The HELP has the pro that it's shorter, it's more simplistic, it's great for large use. The con with the HELP is I think that it's maybe a little less reliable. It tends to cast a really wide net and require some narrowing down of whether or not the individual actually has had a brain injury. It has never been validated. However, it has been shown to be relatively valid. It's just nobody's done that validation study. The HELP was the one that was used in the Nebraska domestic violence study that I mentioned earlier. And then the next is the OSU. The OSU ID form is reliable and it has been validated. It is widely used in research. Many people use the OSU ID. It was the one that was used in the most recent Colorado prison study. But the con with the OSU ID is can be a little bit longer to administer, And it can be a little bit more kind of complex because it kind of requires documenting the different stages of an injury. So it's a little bit more. But like I said, I don't have a preference. I feel that they both fill different needs. So that's why today I thought we would go through both of them. And then, as I said, if you as a professional or as an agency want to adopt one, let us know and we'll kind of help you think through which one would be best for your agency. So some important notes. Both of them are just basic screening tools. They're not actual diagnostic tools. They are, you know, not enough to really provide that definitive diagnosis. You know, positive answers are not really sufficient to suggest the presence of a brain injury. Just because somebody's had a blow to the head does not mean they've had a brain injury. Just about everybody on the planet has had some form of like bonk on their head in their life, but that doesn't mean everybody has a brain injury. So it does take a little bit more looking at it and scoring it and really determining. But what the tools are and what screening is the first step towards identifying a history of brain injury. So I would say, you know, using the tools and then along with your judgment can be used as a basis of further inquiry. Does it mean a referral to the Brain Injury Network to where we can, you know, talk it through with people? Referral to a physician or further observation, you know, for further evaluation. So a lot of times that's what I will do with individuals is kind of talk through them what the results mean. You know, when I go through it and based on getting kind of more of a history of what their symptomology is and what, you know, they're experiencing, I can get a good idea of whether or not I really am pretty confident that they have a brain injury. And then I kind of ask them, like, what do you want to do with this? Does this, you know, would getting a diagnosis be a, you know, access to treatment and access to, you know, services to where it would be a benefit? Is this something that it's just for your knowledge and for you to be able to become a self-advocate and self-aware? Then it may be that the screening tool is enough for you to identify and you to know, like, yes, this is impacting me and move forward with it. So a lot of times the screening tool, as I said, really is just that first step and really then starts that conversation. Particularly if you're on the professional side, it is that opportunity to then add that along with what are the other things you know about that individual and how can this information help, you know, form treatment planning and really help them be better able to function and to access services. So the help was developed in 1991. It was in Alabama, I believe. It was designed to be used by professionals whose primary field was not brain injury. So it started out with mental health case managers, but really they identified, you know, that it could be used by case managers, addiction counselors, law enforcement, VR, just a whole host, anybody that would maybe want to. There are many versions. Some versions are the helps or the help. It kind of depends on how it's gone through reiterations over the years. Nebraska did most recently, it spanned the form to include strangulation for their use with the domestic violence population. We at the North Dakota Brain Injury Network did get permission from Nebraska, and we have expanded the help even further to include all loss of oxygen. So strangulation, near drowning, drug overdose, and then it also does ask about other significant events. So that may include some other things that, you know, like a stroke or a, you know, I'm trying to think of some others, chemical exposure, things like that. So it does ask about those other events. So that's the helps. One of the screening things and what it does ask is what the HELP stands for, is it is an acronym for the different questions. And so these are the different ones. H stands for have you ever hit your head? So, and you know, asking, have you ever hit your head? This is where you can, prompt clients to think about incidents that may have occurred at any age, even those that did not seem serious. The form kind of walks through, consider domestic violence, child abuse, service related, and then it does go through lack of oxygen to the brain, such as stroke, overdose, strangulation. And then ask some sub questions about how many times, when it was, and then, describe how it happened, and has a checklist of the different ways. And then the second question for the E of help is, were you ever seen in the emergency room? And so that's where asking the individual, were you ever seen in the emergency room, a hospital, or by a doctor because of the hit to the head or because of lack of oxygen to the brain? It does have there on a note that many people are, seen for treatment. However, there are those that cannot afford treatment or do not think they require it. So if you were seen in the emergency room is a question, but it's not a mandated in order to have a positive screen. And then it does have some sub questions requiring if there were follow-up recommendations and if they followed those. And then the L in help is for lose consciousness. And so it's asking an individual if they ever lost consciousness, dazed, or confused. It does bring in that dazed and confused. A lot of times individuals may not actually lose consciousness. And then it does, kind of prompt to say, this can be referred to as being knocked out, having your bell rung, etc. And then it does have a sub question that's for how long were you unconscious, and then it has check boxes for different time periods, and then how many times have you felt this way. And then the P in a help is problems in your daily life. And this is where it then asks sub questions related to, are they having difficulty with depression, anxiety, sleep, concentration, memory, and gets an idea of what problems they are having. And really, for screening the help, what you're wanting to look for is, as far as a possible brain injury, is that they have had an event that could cause a brain injury. So a yes on being hit to the head or seen in the emergency room, and a yes to a period of loss of consciousness, or being seen in the emergency room, and 2 or more chronic problems listed in the P. So really wanting it to be that they've had a hit to the head, and loss of consciousness, or been seen in the emergency room and have 2 or more presents under the P. So one of the things that I find really difficult is they have identified as part of the helps that they really want the chronic problems that were not present before the injury. For a lot of the individuals that I end up screening with the helps, a lot of times their injury was young enough that they don't know. So that can be tough. And then I just count it as, they were not present before the injury, because the assumption is that they maybe wouldn't have developed those if they hadn't have had the brain injury. So that's the helps. Is there anybody that has any questions about the help before we move on? Okay. So the next one is the OSU TBI ID. The OSU TBI ID has also a long history of use throughout research. It was developed by the Ohio Valley Center for Brain Injury Prevention and Rehabilitation. And it has been used at the Human Service Centers here in North Dakota. So for individuals accessing mental health services or addiction services through the Human Service Centers, they would have used the helps, and has been used throughout many research studies, as I said. It is set up to be a 3 to 5 minute structured interview. However, sometimes people say that it takes longer than that 3 to 5 minutes. So it's kind of a question. It does provide more detailed information than the helps. I would see the helps as a really good kind of introductory screening, because as I said, it captures that really wide net. Whereas the OSU is really more of a drill down screening, getting more of a better picture of actually the specific brain injuries and how they might be impacting that individual. So it has kind of, they have those different functionalities. So this is the OSU form. It is developed as a one-page form, and it has the different steps. If anybody really is interested in adopting the OSU, we would obviously provide you the form, but also some different information about it. And Ohio, the only thing Ohio State does really ask is they kind of like to have an idea if there are agencies that are adopting it. They kind of like to know who's utilizing it. They do also have modules on their website that are also more detailed and go into kind of a longer, so if an agency were to adopt it, you could utilize those modules as well for like training staff and pieces. So the first step on the OSU, which you could see in the form here, it does have step 1 is all along the left-hand column. And then across the top is step 2 and step 3. Those are kind of your questions. And then at the bottom right-hand corner is the boxes that you would fill in when you're doing it. So we're going to kind of walk through them because it's a little confusing on the form, but once you know how to use it, it works really well. So step 1, for step 1 is really asking 5 questions. It is that panel down the left-hand side of the form. And really goes through the 5 questions. And when you ask the 5 questions, really at that point, you're just wanting to ask the cause of the injury. So yes or no, and what the cause was. So in your lifetime, have you ever been hospitalized or treated in an emergency room following an injury to your head or neck? Think about any childhood injuries you remember you were told about. And then as they just spontaneously answer, if they say, yes, this, yes, that, you just record it in the box of the cause. And then question 2 is, in your lifetime, have you ever injured your head or neck in a car accident or from crashing some other motor vehicle like a bicycle, motorcycle, or ATV? And again, you just check yes and the cause. If for some reason they then kind of start giving you more details, you can stop them and say, great, let's finish up with these questions and we'll get to I'll then ask you about those more details, but you can kind of jot notes in the other areas as if they give you kind of that unsolicited information. The next one is asking about, have they ever injured their head and neck in a fall or from being hit by something, falling from a bike or a horse, rollerblading, falling on ice, being hit by a rock. In your lifetime, have you ever injured your head or neck in a fight, being hit by someone, or from being shaken violently? In your lifetime, have you ever been nearby when an explosion or a blast occurred? So that's kind of step 1. You just go through asking all the different types of brain injury to just determine if they have a yes or a no and the causes. And then moving to step 2 is where you follow up with any of those yeses to the previous questions with questions about loss of consciousness and how old they were at the time. So asking, were you knocked out or did you lose consciousness? If yes, for how long? So in this step, you would go back and say, previously you said you were in a car accident. How, were you knocked unconscious in that car accident? If yes, for how long? Were you dazed and confused? Did you have a gap in memory? How old were you? And so at this time, you record the step 2 of their loss of consciousness and, if they've had dazed and confused, memory gap, and age. So once they're put together, as you can see previously, once they're put together, you would have the cause on a line, and then across the step 2 is filling in the more details. So, and then step 3 is asking about a period of times of repeated head injuries. I can say, having given the OSU ID before, a lot of times you will have individuals that will have a period of maybe 5 years. So when you ask that first question of, have you ever, had, an injury to the head from a fall, they might say, well, there was this time in my 20s where I was getting blackout drunk every night and I was falling a lot. And so you really can't put it down as individual times because they don't have those individual numbers or anything. And so that is where you would identify this here in step 3. This is also true a lot of times with domestic violence. Individuals might say, I've had a period of, I was in an abusive relationship for 6 years and, repeatedly had that. And so really you're kind of just getting from them what age were they during this time, what was the typical effect, did they typically have a loss of it? So you're more looking at the typical effect from that an episode during that period of time. So, and then that's it for the OSU ID. So that then finishes it. And then from the OSU ID, you're really wanting to then interpret those findings. A person may be more likely to have going problems if they meet any of the following. And these are based on research from Dr. Corrigan in Ohio, who does this research. He really found that these were the things that led to people most likely having ongoing problems after a traumatic brain injury. So really looking for a worse injury. Have they had an injury that led to a greater than 30-minute loss of consciousness? So having that greater than 30-minute loss of consciousness is more likely to have an ongoing issue than somebody with less. When was their first injury? So really they found that individuals who report a loss of consciousness before the age of 15 are more likely to have ongoing problems than individuals with that loss of consciousness over the age of 15. That has to do with their ability it really affecting their ability to acquire new knowledge, and that they haven't had that time to reach adulthood yet to gain those skills to fall back on. So if they had the injury before that chance, then their kind of young adulthood period, they're already injured during that time, and so don't have those skills to gain to fall back on. And then the other is having multiple injuries. As I said previously on that understanding of multiple, if an individual reports a period of where 3 or more blows to the head cause altered consciousness, or having 2 or more brain injuries within a 3-month period, that having that multiple leads to a more likelihood that they will have ongoing issues. So that kind of ends the OSU as far as interpreting those findings and then being able to see that. And then I would say, after following up, if you do a screen, any of those, and an individual screen's positive, welcome to obviously refer to the North Dakota Brain Injury Network. We then can provide more information. We do have more detailed symptom inventory that we have gotten and are able to use that can, assist with that. As I said, determine if obtaining medical records is an option, if follow up with a primary care provider maybe would be warranted, or is a neuropsych warranted. Really be able to determine what would be the best course of action for that individual now that there's a potential positive screen. And then also for you as a provider, being able to provide that direction of some information that would be help working with that individual. So how can we help? Obviously, if you want help establishing screening in your agency or more information about screens, happy to help with that and kind of work through that. We do have some cognitive guides, and as I said, that cognitive symptom inventory, access to support groups across the state. We do have our resource facilitation program that does provide follow-up support and information for individuals and accessing services. We do have access to what's called the AHEAD. So the AHEAD is a brain injury curriculum designed for individuals that are recently screened. It was developed by Colorado as part of their prison screening study that they were doing. And so the AHEAD is set up and it's done as it's easy for anybody to administer. So it is something that could be administered by within an agency if you did do a screening and then identified a group that would maybe want to learn more about it and participate in it. So we do have a lot of those resources that are available and can help out. And then, there's our contact information, and you're welcome to kind of contact us and if you have any questions or want any help. So I don't know, I open it up to any questions. If anybody has any questions, if this helped at all, as far as additional information about screening.
Okay, Sandy raised her hand. I'm going to unmute you, Sandy. There we go. Oh, maybe not. You might have to unmute yourself.
I got it.
Okay, there.
So a question, when you were talking about the criminal justice, that there's 60 to 87% that have brain injury, TBI, are any of those related to that current incarceration? Like did they acquire that brain injury that led to their arrest? Like, an assault or something like that? Is that broken down at all, or is it just a lump number?
It is usually, when I have seen it, it is usually a lump number. I could do some digging in to get that, but predominantly it has been shown, just kind of like the homeless population, that it usually is an earlier previous injury, not a recent injury. For the most part, it's kind of childhood injury or adolescent, previous injuries, not related to that episode.
Okay, thank you.
Any other questions? Nobody? So was it beneficial learning about, brain injury, getting an idea of how to go about screening? I think screening is something that, as I said, it's something that we should really start doing more of. I think that in working with individuals, it's a benefit. Really having that idea, it is shocking when you start doing it, how many individuals do have a brain injury out there that we just are not, recognizing. Right now, as far as, for us moving forward, we have been talking with, the Department of Human Services as they start rolling out new and different things related to, like the 1915I Medicaid state plan amendment that is changing, and as those services coming about, ways of integrating screening into access to some of those services, and so that we can get a better idea of where individuals with brain injury are within our different populations. Okay, so Donnell says, are these screenings being completed by the medical professionals in the ER or hospitals when someone is there for a loss of consciousness, etc.? So good question, Donnell. So usually I would say no. Is the best way to answer this. When somebody is seen by medical professionals or like in the ER, they really are looking at, and I see Debbie entered in GCS, so Glasgow Coma Scale. Really, they are looking at that loss of consciousness, that Glasgow Coma Scale, and really they're making that determination there. For the ER, really the focus is saving life and the physical. So the disconnect that really happens with brain injury, and one of the reasons why, this type of screening is so important, is we really have two systems at work here. You have your medical system where somebody is accessing like emergency room services or even with their provider and things. That really is focused on physical, and the primary focus being like, you know, saving their life, keeping them conscious. You know, are they going to, do they have something that's going to make it worse, like a brain bleed or something like that, that's going to cause it to get worse and it not get better? But then they're pretty much discharged and sent on their way. At that point, their focus is not ongoing recovery. Those are not providers that have really background education or understanding in things like cognitive learning and emotional regulation and all of those components that our brains, you know, do. Really, their focus was that physical. So what ends up happening is there's this disconnect that people have that physical episode and they follow up. And even for individuals that access like, you know, inpatient rehab and things like that, inpatient rehab, still a lot of the focus is really on things like gaining back physical skills, like walking. It might be gaining, you know, speech skills if somebody's, you know, having difficulty speaking, those type of things, but really doesn't have quite the same understanding of like real world functionality. Well, then what ends up happening is, particularly in the behavioral health field, you have professionals that are out in the real world, you know, doing behavioral health. So it might be the populations I mentioned, criminal justice, homeless, you know, but it might just be like counseling services, any of those type of things, that the individual, all of their other symptomology comes up, you know, some of the cognitive, the behavioral symptomology, those things start interrupting their daily lives. But that's not really something that the ER provider or the medical provider at the time of the injury would have dealt with or relayed to them. So they don't really know that's not really who to go back to. And if they do go back to, that provider doesn't have much information. But within the behavioral health human service field, it's not really something that it's set up to handle, that is widely, you know, embracing it as, oh yeah, this is our area. So brain injury ends up being in this big like gap in the middle. So Marvin Nelson provided, our state agencies like WSI using these screens, or if the doctor doesn't do it, the worker is just out of luck. I would say WSI has gotten better, particularly over the last 10 years. I would say thank you for your work on that, Mr. Nelson. So, because your work has definitely helped that in working with it as an agency, and they're gaining a better understanding of brain injury. So they are. But I think one of the problems, even with WSI, that can be difficult is if a provider sees an individual at the time of injury, then it can be difficult for if that person then has follow-up symptomology. And one of the problems that we kind of see with brain injury is the level of severity of brain injury is based exclusively on that Glasgow Coma Scale that Debbie had mentioned. So exclusively on that Glasgow Coma Scale, which looks at things, loss of consciousness. But we don't change the severity of an injury if the individual has ongoing issues. So it's not something that we come back, 3-4 months later and say, oh, they had a moderate injury because they, only had a 3-hour loss of consciousness, but now they're having, these ongoing problems. So we're going to bump them up to a more severe injury. So sometimes that can be a disconnect. I will say, one of the things WSI is doing more of is referring for things like neuropsychs, having a neuropsychological exam that kind of looks at that follow-up cognitive functioning. And WSI is doing a lot more of vision, vision screening, because vision can be so impacted after brain injury. Another thing, not to call out WSI, but it's what, Marvin Nelson mentioned. I did have last year at our conference, we had somebody that spoke on the gut-brain connection and a session on that really talked about how much our gut and our digestive functioning is controlled by our brain. and how, after an injury, you really can have a lot of digestive issues, and really how to repair that and work on that. And specifically, somebody from WSI did come up to me after the session and say, wow, thank you for having this session at the conference, because I've never even considered, approving digestive things for a WSI claim before, but now, for brain injury, but now I see how important it is and how much it matters. So it is providing that ongoing education. So are there other questions? So Debbie says, I found myself screening myself when you were going through the help screen. Hard to know if a symptom like memory worsened after the incident like you mentioned, especially if you sustained an injury during your childhood. Yeah, pretty much exactly, Debbie. I'll disclose, because I've disclosed many, many times, my first injury was a moderate injury at the age of 16 months old. So I have no idea how I would have been without that. My second injury was a severe injury at the age of 7. And then I had 2 very significant concussions in high school. So having had 4 injuries, one of every level of severity, and all before I graduated high school, I really have no idea how I would have been without them. But I will say, I did not in any way self-identify as somebody that had a brain injury before I got this job. And my father was a physician. My father was a physician who worked at a hospital. In fact, when I was 7 and I woke up enough in the ER when they ran a key down my foot to ask them if they'd ask my dad if they could do that. Because being a child of a physician, I was raised that, I never got medical care without my dad's permission. And my mother was a social worker. So if there was anybody that should have, having had 4 injuries before I graduated high school, had the level of support and identification, it really was me. But it was not seen back then, was not in any way. But then when I got this job, I did really start to see some of the traits in myself, see some of the things that I do have difficulties with. And, so it really was that where screening it and then just thinking about it and kind of doing that, is it possible? And I'm going to add that possibility to my repertoire about myself, to how I maybe, think about things. And giving myself a little bit more permission on adopting accommodations. Yesterday I was doing a presentation for an addiction group, and we were talking about how much we beat ourselves up on being the perfect whatever, that for somehow being able to go grocery shopping without a list is like a badge of honor or whatever. And so kind of dumping those things and realizing there is no normal and there is no perfect way of doing anything. So whatever is going to work for you, whether you have a brain injury or whatever, is what's going to be most effective. And so the more that I kind of identified that and then learned about brain injury, it helped. And so I think that that is, true, is that sometimes you can look at it and start to think, wow, have I had any significant? So other questions? No? Okay. Well, we're always here. We welcome any feedback or any assistance. As I said, if you would like either access to some of the, the 2 screening forms that we used today, or you would like more information about them, feel free to send either myself or Carly an email. And we're more than happy to kind of talk to you about how you could adopt it and how to make it a part of your practice. And this recording and the slides and access to the survey for the CEUs will be online. Usually it takes about a day to get online, but it'll be there. Thank you.
Thank you, Rebecca. Great information.
Thanks.
Thanks everyone for coming.